Here we'll look at pupil contraction and dilation. So to get a pin-like reflex in someone's eye, the pupils constrict because of parasympathetics. So you need cranial nerve 2, which takes information in, so afferent, and cranial nerve 3 from the brain to the eyes, so efferent for motor and parasympathetics. Let's pretend we have light shining through your left eye, and that stimulates your retinal neurons, and they travel through your cranial nerve 2, through optic chiasm, then travels contralaterally, and then eventually synapses in your pretectal area of your superior colliculus, and then synapses in 2 places, your Edinger-Westphal nucleus here, and also your Edinger-Westphal nucleus over here. And to get to this point, you have to decussate across the posterior commissure, also known as your commissure of your superior colliculus. And it is a very similar pathway for blue from your temporal retina. So you travel again through your cranial nerve 2, through your optic chiasm, and then you travel ipsilaterally, keep on going, synapse again at your pretectal area of your superior colliculus, and then you synapse at your Edinger-Westphal nucleus here, and then your Edinger-Westphal nucleus over here. After synapsing at both Edinger-Westphal nuclei, you travel down as a parasympathetic part of cranial nerve 3, synapse at your ciliary ganglion, and then innervate your sphincter pupillae muscle, which affects pupil constriction, and the ciliary muscle affecting accommodation. And same thing for the other side. So overall, nasal retina, contralaterally, temporal retina, ipsilaterally, and then both involve the Edinger-Westphal nuclei, and both decussate at the posterior commissure. Before we talk about lesions of cranial nerve 2 and cranial nerve 3, briefly talk about the pupillary light reflex. So both eyes constrict when light is shown in one eye. So if you shine a light in the right eye, both pupils constrict. If you shine a light in the left eye, both pupils also constrict. So let's pretend you have a lesion in your left optic nerve, and you shine a light into your right eye. Information goes through to both Edinger-Westphal nuclei, to both cranial nerve 3, to both ciliary ganglion, and causes constriction of both pupils. However, when light is shown through the left eye, no information gets through, and as such, neither eye will constrict. A little confusing is that this is labeled 1, and it says right here, afferent pupillary defect. Checking online says it's a complete lesion of cranial nerve 2. There is no afferent pupillary defect. That will be discussed next. So for the swinging flashlight test, for a normal, unaffected individual, when you shine light into the right eye, it causes both pupils to constrict. And as you are swinging the pen light over to the other eye, to the left eye, both pupils dilate a little bit. And now when the light is shining into the left eye, both pupils constrict again. So in short, you do not see any pupil dilation in the illuminated eye. Now for a positive swinging flashlight test, more specifically a positive afferent pupillary defect, when light is shined through the right eye, which is unaffected, you get normal constriction of the pupils, and as you're swinging the pen light over to the left eye, both pupils dilate a little bit. But now when the light is shining into the left eye, which is lesion, you only get a very small degree of constriction. And this occurs in both pupils because of a decreased response to light from the afferent defect. And then when the light is shined back to the right unaffected eye, you get normal constriction again of both pupils because of an intact efferent path. So overall, when light is shown in the affected eye, you get less pupillary constriction than light shown in the unaffected eye. And because of this, the left eye looks dilated, and it's also called a Marcus gun pupil. That sounded pretty confusing to me, so I'll repeat it one more time. So the right eye, when light shines through it, you get normal constriction of the pupils. When you shine a light into the left eye, you get a very tiny, small degree of constriction. So the difference between the two, when you keep flipping the light back and forth, it appears that the left eye is very dilated, and because the left eye is lesion, it looks dilated, it is your Marcus gun pupil, and it is a positive afferent pupillary defect. And to talk a little bit more about the afferent pupillary defects, remember that when light is shined through the left eye, because you have that lesion here, not enough information goes through, and in turn will not affect your parasympathetics of your pupillary constrictors to constrict the eye. So because of that, you only get a very small degree of constriction because you don't have enough, parasympathetics to constrict your eye, and then as such, it looks dilated. Also, a positive afferent pupillary defect is due to either a lesion in the retina or cranial nerve 2, and common causes, you think of multiple sclerosis, your optic nerve ischemia, large retinal detachment, central retina occlusion, or central retinal vein occlusion. Next, we'll talk about anoscoria, and that is unequal pupils due to lesion in the molar tract, and which leads to increased intracranial pressure, and that finally leads to on-call herniation through incisure of the tentorium. Now let's say you went to a cadaver, you somehow got a cranial nerve 3, and you took a cross-section of it. So you take a cross-section and you find out that it has 2 parts. So roughly on the outside is your periphery, which contains your parasympathetics. Inside contains motor. So let's say your herniation of the brain is not so bad. It only affects your parasympathetic, so your findings will be dilated pupil, also called blown pupil. And if your herniation is extremely bad and it impinges on your motor area, you will get pretty much all your motor to your eye will be affected, sparing your superior oblique and lateral rectus muscles because they are not innervated by your cranial nerves 3. And finally, if you have a lesion right down over here, you get Horner syndrome. So symptoms are meiosis, constriction, anhidrosis, and slight ptosis.